all for joining us. We'll get started. I'm your host, Bridget Wallace. I am a physical therapist and located in Austin, Texas. And I have to, before we get started, I do want to introduce Cynthia Ryan for taking the time. She was just doing a little wave there. And Cynthia, if you want to unmute yourself, Cynthia is the executive director of the Vestibular Disorders Association. And I just can't say enough about everything that they've done. I've been a professional member, I think, since 1996. So my privilege here is just to host this. This is really to answer questions you may have, but what an honor to have her on here. So Cynthia, if you want to say a few words and I think, thank you for everything that your organization has done. And I'd love for you to if anyone doesn't know about Veda, let you tell them a little bit about your organization.
Sure. Thank you. I
Yes.
didn't expect it, but I can always talk about Vita and vestibular disorders. Hi, everyone. As Bridget said, I'm with the Vestibular Disorders Association. I've been working with Vita for 12 years, but my personal connection is actually through my mother, who has Meniere's disease, vestibular migraine, and BPPV. I've lived a lifetime with vestibular disorders, and I really understand their impact, and I'm just honored to be able to support vestibular patients and the healthcare professionals who provide care for them through the programs that Vita offers. All the patient education stuff, our conference, one-on-one patient support, and I guess I'll just wrap it up by saying if you need anything, if you need support groups, if you need information, articles, anything, just contact us, and we will help you in any way that we can.
I know Liz is off camera too. She may not want to turn her camera on. She's actually not been feeling well. I want to acknowledge Liz because in 1997, she was one of the, or 96 or 97, one of the first vestibular patients post-op a labyrinthectomy that I had ever seen. And we've remained friends. She worked with me for a while and has just been an avid supporter. So, Liz, I appreciate you joining and the other familiar faces. So what I thought I would do with this one is really, this is the opportunity for you to ask questions, but I thought I would just share my experience as a healthcare provider, um, and how we, I'm not going to say I can't speak for other healthcare providers, but how I often listening about dizziness. And it's an umbrella term and it's unique to you. And I think, I've been in this space since 1996, and I still say, once you've seen one person with dizziness, you've seen one person with dizziness because everyone is unique. And, you go from healthcare provider to healthcare provider, and people think about the word dizziness differently. Sometimes it's like, is it spinning? And you get tired of the people asking, is the room spinning? So I'm going to just talk about how I look at dizziness, and I've put it up here as a word. And then in my head, I try to categorize it by vertigo. Is it spinning? Either the world is spinning or you feel it in your head. Unsteadiness. So maybe you don't feel it in your head or see things spinning, but you feel unsteady, or it could be lightheaded, almost like faint-like. And then another kind of subset or subcategory is maybe you feel a sensation of falling through the floor or rocking or bobbing sensations. Now, there's a whole other slew of endless words that you may feel, but when I'm listening to dizziness, that's where I start. And then I want to know, is it persistent? Is it more kind of all the time? Or is it episodic? Does it come and go in clear episodes, or both? And many people have more than one type of dizziness. Maybe they have vertigo with certain position changes, but they also feel unsteady. Or maybe they feel lightheaded when they stand or bend over and then don't like to walk on uneven surfaces. So it's not about having one type or it being the same. And we are guilty. In fact, it's part of our initial paperwork for you to rate your dizziness, yes, no, sometimes. And that in itself is a challenge because people are like, well, yes, I am at this time, but no, I'm not here. Or sometimes, but yes and no, or rate it. We say rate your dizziness from 0 to 10. Well, at 9, it's a 10. At 3, it's a 2. And so it's really hard to rate dizziness because it's not always the same. I know we do it. I'm guilty of it. And there are some things, there's some reasons why we do it. And so I just ask for your patience, but please just know that I really get, and I hope whoever your healthcare provider is gets that you can't put this in a box. It's not the same all the time. It fluctuates. You maybe have more than one type, and we can't see dizziness. Not only is it the diagnosis and adios syndrome, sometimes you get the diagnosis and then it's like, bye, but it's a silent syndrome. You just can't see it. It's not like you're walking in with a brace or, on your knee and people are like, what happened? And I did a podcast on, I look normal on the outside, but feel like shite on the inside. And it's just because people don't feel good inside, even though they look like their normal selves on the outside. And so that's so frustrating. And one thing I wanted to talk about today about dizziness is, again, oftentimes you're like, are you spinning? And it can be unsteadiness, like I mentioned earlier. So if any of you have like burning or cold in your feet, or you have peripheral neuropathy, like you don't have normal sensation in your feet, you may not have spinning, but you don't like to walk across an uneven surface or walk outside. You have to think about balance all the time. And that's limits your daily life just as much as someone who's experiencing maybe dizziness in their head. And so that's unsteadiness is kind of, we consider that it could be a type of dizziness. You just don't feel it in your head, you feel it in your feet, and it makes you feel really off when you're out trying to move about your environment. So those are, I have received a couple of questions by email, um, actually by a couple of people who couldn't be on today's call. So I thought what I'd do is I'd start with that and then kind of open up the floor. There's no certain length of time here. I mean, we don't have to take up the full hour. I don't want you to think you have to start thinking of a bunch of questions, but I will start with a question that I did receive, and it was someone that couldn't be here, but said, what I would like to share is and ask about. They were asking me if I use virtual reality to help people's dizziness, because it really helped them, and they felt very fortunate that they were working with someone. We do have virtual reality. Um, we can use it through glasses. We can use it in a big dome that's like immersive it's called you don't need to know the name. It's just a big dome that you get in and the floor can move or the surround can move. And that's another immersive type. And I am a proponent. I don't even think we know how beneficial virtual reality might be. And so I'm super excited about the opportunities, but I'm cautious. But because you have to think, if you've never put on a headset, you suddenly you see things, but they're not your reality. And so you suddenly can't really use your vision. And studies show that 80 to 90% of what we process goes through our visual system. And so you just have to think our eyeballs are like little computers trying to pick up as much information as possible. And so when you put something on that's not our reality, your brain is like, what is my reality? And it can feel very confusing. And if the surround is moving, like even my hands are moving, I used to think all these years I would just sit on my hands and not move them because people are like, do not move your hands. Um, is it can make you feel motion, actually have motion sickness, feel like you're going to fall. But here's what studies show, which I find super interesting, is when people are put in a situation where they should be using their inner ear for balance, or they should be using their feet for balance. And this is only in research. I'm sorry that y'all can't go through this and experience, this kind of study, but it shows when there is what we call a sensory mismatch. That means what your eyes and your ears and your body, they all have to talk to each other. It's that they're not matching, and that when you should be using your inner ear, you might be using your visual system instead. Or when you should be using your feet for balance, you're in your visual system. And when you're in your visual system like that, you're in fight or flight. That's what can happen is people can go to fight or flight. And we're in fight or flight, we're trying to hear as much and see as much. And so we're not tapping into other systems because we're in a reflex to protect us. And we're not wired to be in fight or flight 24/7. We're not wired for it. We're wired to run from dinosaurs for little short periods. But so when we have the fear of falling, when sensory information overloads us, when we feel like we want to go like this, like have a startle response, we are in fight or flight. And if we're in fight or flight, we're not using our higher evolved balance centers to orient us. And an example, I feel like I'm talking too much. And an example, when you think about a baby that if you've had kids or you have grandkids, you hold a baby up before they're crawling or walking and they have a startle response because they don't know where they are. And it's cute. It's like, oh, they're so cute. And then when we learn to crawl and then walk, we integrate it. It goes away. We don't go around going like this for our balance until something happens. Maybe we lose our vision. Maybe we lose sensation in our feet. Maybe we have a concussion. Maybe we have vertigo. Maybe we have personal stress. Maybe we have physical stress. Maybe we have emotional stress. And that stress brings us into the startle. So if you find yourself startle, then we have to be very cautious about the type of exercises that we give because we don't want you more in fight or flight. We want you into your higher evolved sensory systems. And some we can't change, some we can. And so virtual reality, I think, brings a really amazing opportunity for this. But if you're in it and you're in fight or flight, then we may have to try something else and ease you into it. But I like it because of the sensory conflict it creates. And it helps us, like if you're in virtual reality, you suddenly have to learn, oh my gosh, I have to use my feet. Or maybe you're using your inner ear more. And so it has amazing possibilities. But if it's making you afraid, then we may have to try another avenue until you feel more confident. So I love virtual reality. I just, in all types of rehab, in this type of rehab, if you've ever been, and I recognize a majority of you, you've been through vestibular rehab, is we want to put you in these uncomfortable positions. We want to make your balance better, but we have to be cautious with that. And unfortunately, we just don't know a lot about it. There's a part of your brain, there won't be a quiz or anything. It's called the velocity storage mechanism. And just think of it, it's in your brainstem and it's a filing cabinet. And it uses and stores information and it picks what it's going to use and doesn't pick what it's going to use. We know very little about it in humans, but that's where we think motion sensitivity comes from. That's where we think MDDS, mishap in MDDS maybe comes from. in the issue with that is that we're not, I want to think of a better word, we're not suppressing information. We're in fight or flight, so we're gathering as much information. And so if we're gathering as much, we can be sensory overloaded. And then that can create a startle response. And so oftentimes what we need is to calm our system down through grounding techniques, through deep breathing, through putting your feet on the ground, doing a joyful activity. So it's not always, we don't always need to be about providing sensory information that creates that startle response. But there are, again, that was a long explanation about how I feel personally about virtual reality. I think it has amazing opportunities, but I think we have to, as with anything we do, use it with caution. Okay, I have already talked too much. That was one question I had. Someone had asked, can you share any strategies about describing my symptoms to my healthcare provider? And so that's where it may be too much to remember. Of course, this is recorded, but I did do a podcast on this, and I can send out a link because I provided you handouts. I think it was called Out with the Old, In with the New. And it's kind of trying to move away from the way we always think about symptoms and trying to put them more into categories and not be so, if you want to rate it, but not putting the pressure on you to be, is it a 0? Is it a 5? Is it a 10? Really what we want to know, is it persistent? Is it episodic? What makes it worse? What makes it better? And those give us clues. Like if you're dizzier when your head is still and things are moving around you, it's probably not your inner ear because your inner ear gets to like rest when you're being still. If it's more when you move your head quickly or you're in the dark, then we have to consider the inner ear. But we cannot separate the inner ear from your eyes, from your neck muscles, from your emotional system, from the rest of your body. Because your ear, for instance, your inner ear sends messages to your brain and talks to all your eye muscles. These little neck muscles right here help with eye alignment. Part of your inner ear goes all the way through your spinal cord, getting feedback along the way to help you step on time. I mean, these systems are intricate, they don't work in isolation, and they're very connected to your emotional system. And we can never, ever underappreciate the beauty and the complications when something in one or more of those systems is disrupted. So, do y'all have any questions? And Cynthia, don't be afraid if you have a question, like to unmute.
I was going to jump back to what you were talking about with virtual reality, because I think, I think it's hard to imagine what virtual reality for treatment of or evaluation of vestibular disorders looks like. I think at least I do. I think of, these big goggles and then I'm, then I'm in Narnia or whatever, so I remember talking to a couple of people that are involved in this and learned that, like you were saying, you don't want to start too fast. So virtual reality, I'm guessing, so this is the question, is it's not like putting you in this whole different environment. It starts like minimal, like with a blank environment and just a few things moving, right? And that kind of gets to, I remember Rachel Wellens talking about this at our conference, the dosing.
The dosing.
Of the vestibular rehab, starting with a really low dose. I love that term.
Yeah, and it can start in sitting where you don't feel like you're upright, having to keep your balance. And even like there's virtuality apps for anxiety that actually you can practice models of deep breathing and hear nice music. And so this isn't about being in a chaotic, thank you for bringing that up. It's not about being in a chaotic world. If I was going to put someone in virtual reality, I would start simple. And if there was any kind of scene that I could pick to relate that person thought was joyful, I would start there. That's even better if it's an environment, it's like, oh, I love the ocean. Okay, what do we have with the ocean? So this is going to be like you walking on the beach. but maybe we just start in sitting and they can look around and see and then come to standing. But absolutely, it is super gradual dosing that doesn't feed into a startle response. And if it does, can we ground ourselves during that stimulation to minimize and actually stop the startle response, begin to think about our balance? And it's more about, if you have a startle response, it's not about completely staying away, but gradually dosing to see if we can get it calmed down. And if we can't, then that stimulation is too much. And then there's all kinds, we can't get them anymore, but we used to keep them in the clinic, and they're like little glasses that you just set your phone in, and then they make it 3D. There's not anything on your head. The nice thing about some of the headsets is that you can actually put nice music in them as well. Or it can be sounds that mimic the scene. Because, I mean, telling you this, Cynthia, is like, balance is the sixth sense, but we talk about balance, we talk about the inner ear, and half of the inner ear does balance and half of it does hearing. And so hearing and balance are connected. You can have hearing loss without balance loss without hearing loss, or both. Any other questions? So, or if you like, what were you hoping to get from being, listening into this? Gary,
Bridget,
y'all are on mute. If you want to unmute yourself, there you go.
Bridget, can you hear me?
Yeah, I can hear you.
Oh, sorry, Gary. My name is Teddy, but I think you have the first question. I will wait until you're finished.
No, go ahead.
Well, thank you. Bridget, I just wanted to ask you, I have a recurrent issue when I go in stores that have tall ceilings, fluorescent lights. Sometimes I will feel dizzy. Sometimes I might even feel faint. Is that more likely an anxiety issue, or does that go along with these vestibular Meniere's type things to feel like that in a big open space with crazy lighting?
I think it could be all of the above. And unfortunately, like when I say things, I have my own intent. And what I want to say is not as a disclaimer, but really as, the word anxiety and dizziness, they're hard to separate. I'm going to tell you, in all the years, I've met one person who didn't want their vertigo to go away. She didn't want it treated because she had BPPV and she thought it was a cool thing and that she could make her eyes move. And that's not right. Because every single person I've seen since 1996 who has dizziness has some form of anxiety about it, because we don't like to be dizzy.
Mhm.
I think so. When I talk about dizziness and anxiety, what I don't want people to hear is like, oh, you must be anxious. I mean, anxiety is real. It is a physiological response in your brain that affects your neurotransmitters. It is real. It's not, and which comes first, sometimes we don't know. So when I think about a store, that is so common, but there's so many factors. There is all the information in the periphery. So if you think about, here's your central visual field. This is central. Here, everything out is periphery. If you're in your central visual field, you're in your sympathetic nervous system. That's just the way we're wired. When you're in your periphery, you're in your parasympathetic. So sympathetic, parasympathetic. So if most people who feel dizzy, unsteady want to be in their central visual field so they know where they're going, and they minimize all this out here because it minimizes the input. The downside of that, it's out there that tells you where you are in space. So we get it's called central binding or focal binding, where we get locked into our central visual field. So when you go to a store, you're thinking, I don't want to process all this. It's too much. It's shelves, it's fluorescent lights. And I see Cynthia actually gave you a link to information they have on their website about, we call it supermarket syndrome. So it is very common. Push a cart, that provides feedback of where you are in space through your body.
Mhm.
Think about tinted glasses. There's rose-colored glasses that can minimize, there's also blue tinted, but I think Cynthia, I'm going to ask you if you can type it in since I'm talking, but it's FL41. And Cynthia, I don't know if y'all still have a link to rose-colored glasses on your website. I know that there used to be a distributor, I think, linked to your website, but wearing that, I'm not saying like just cheap earplugs in your ears to block out all sound, but consider just over-the-counter musician earplugs, which block out some of the sound but have a filter so that you can talk to people. We're not talking about just to take everything away. It might be beneficial to wear a hat so that it minimizes some of that overhead. But yes, it's a very real thing, and maybe it's the stimulation that's causing you to feel anxious. I don't want you to think, oh, this is just in my head and I'm anxious and I can't go to the store. There's a lot of reasons that you may feel anxious when you go to the store. So if there is a smaller store that you can go to where there's not as much stimulation, but it is the bigger the store, the more we have to process. And it's a big challenge for you.
Yeah. Well, thank you. And thank you, Gary, for letting me interrupt you there.
And Teddy, I hope you're doing well.
Thank you. I
You're
can't wait
welcome.
to come back and see you at some point.
All right, Gary.
Okay, everything that you've talked about, I seem to have. And on top of it all, a couple of years ago, I was diagnosed for onside. Help me on.
Late onset Alzheimer's.
Yeah. And so I've got that to mess around with, where I sometimes don't know where my own voice is.
Mhm.
And so it's past the onset. But we're going to have a few doctors here this week.
Yeah, we're you want me to tell her?
Yeah, go ahead.
Yeah, we're going to Lubbock to the Texas Tech Health Center Clinic, whatever it is, to see Dr. Ken Friedman, who's a neuro-ophthalmologist,
Mhm.
to see if he has any insights, any testing, and a part of this that y'all are talking about is real helpful for us because you were talking about talking to
Mm-hmm.
the professionals, and we've gotten a lot of blank stares from the people we've already been to see, particularly out here. So that's been very helpful, and I would like to get, if I don't know how to access it, but I believe you said you did a webinar or a Q&A or something about how to talk to professionals. So I think that, or doctors or whatever. So I think that would be really helpful for us.
And I can you don't have to listen to the podcast, but I'll definitely give you a link to the podcast. But I can send the downloads of, I added a couple of downloads that you could consider and even take to your provider.
Okay.
Unfortunately, everyone's different. Some people are very resistant to someone coming in or mentioning the web. And I mean,
Yeah.
I'm a healthcare provider, and unfortunately, patients have had to empower themselves. And that's like the one thing about Vita. It's an organization to empower patients because it's poorly understood.
Yeah.
In dizziness, you have to spend time with people to understand the causes. And it's cognition. And I'm sorry I didn't mention, but people can have dizziness from cognitive decline. And, we think about balance as being a reflex, but in that reflex realm of time, they're in milliseconds of a reflex of an inner ear reflex to catch your balance. In the last, 180 to 220 milliseconds is cognitive. So we do see a decline in balance. We can have dizziness related to cognition, a decline in cognition. And so it's, important to try to understand what can be changed, what can't be changed. The brain has an insane amount of neuroplasticity to be introduced to new concepts. So new activities for if we can't get one part back, what can we get back? What are the things we can change? With cognitive decline, we see a change in ocular motor. It's not just about vision. When we think about eyes, we think about how well do I see? Your eyes are so much more than what you see.
I know.
They coordinate, they give you depth perception, and with cognitive decline, we see eye movements diminish. And so reading can be more difficult. Eye teaming, depth perception, all of that can be more challenging. So more than just looking at the nerve and is the nerve working? How well do your eyes move? And how well do they move together? And even though you may not like it, I'll give you one activity, each of you one activity to do. You can do it in sitting, but don't forget to move your eyes out into the periphery. So if you're just sitting down, like jot your eyes over and find a target. If you find a place where you look and it makes you want to blink, don't look there. That's a place your brain doesn't like. Blinking is a sympathetic nervous system response. It's like a startle response from our eyes. And so if you look somewhere and it makes you feel uncomfortable, look to something else that gives you joy, a color, a picture, but use your vision and your parasympathetic, which is rest, digest, and recover, to help calm your nervous system down. Because when we get upset, we just want to be right here, right here. And sometimes you have to be right there.
Right.
And then when you're ready, move out into the periphery.
Any questions about the doctor's visit or any other questions for Bridget?
No, we've doctor's visits.
All right.
Ah,
All right. Well, we're sending you hugs, Gary, and
thank you. A little thing that we had with the doctor. No, I won't mention any names. But you want to run that up?
You mean Odessa?
Yeah.
Yeah, okay. Well, we were at an ENT and we went through all the tests that they had, and it was a whole series of tests. And at the very end, he said, "Well, so he's an ENT, ear, nose, throat." He said, "Well, it's not the inner ear, so it must be central nervous system, something like that," he said. And then so Gary asks him, "Well, could it be my eye? Could we talk about something about my eyes?" And he just said, "Well, I don't do eyes."
Mm-hmm.
And that was the end of the conversation. Not, "Oh, I know a good ophthalmologist in Midland that you might want to talk to him." I mean, the professional skills there were a little bit lacking. And I was really shocked. And Gary was kind of shocked and we have not been back to that guy. But
Yeah.
so,
Well, and it is unfortunate
funny.
that healthcare has become so fragmented and siloed. I mean, I'm in my own silo.
Yeah, well,
I hope
Yeah.
that if I can't recognize something, that I can at least provide resources. But
right.
it's an unfortunate experience. I think, if y'all haven't been on the vestibular.org website. You know, we want to be heard and we want to be seen, and that is by nature. And if you want a community to be heard and seen, you should visit I don't say you, that sounded bossy, you should. I recommend looking at the vestibular.org website, because that's part of what it is. It's a support system. And I don't even know how many times Cynthia has heard what you've just said. I mean, I've heard all the time, but I may be seeing one patient at a time, much less someone who's executive director of an entire international organization that is a shared story from around the world, unfortunately. And so it's like we're just having to pull together. That's what I think that's why we're here. You know, what can we do together? We're bigger, better together. Um, I'm sorry that you had that situation, and I'm sorry for all the people that have that situation. But I do think there are places and spaces that are trying to change that so that people don't feel alone. And I think because that's what we don't want you to feel. You know, I mean, I'm from a small town in the Texas Panhandle and 100 miles away from a medical facility. And so, you know,
Look,
a really big sense of community, but also knowing that there can be limited access to care. And that's kind of why I do what I do today, right? Is you're trying to have that community while still giving people as many opportunities and resources as possible.
Thank you.
one little thing, we've started by ourselves. We started a little thing about the doctors and what we're doing. He says, yeah, we're going to see the 15-minute doctors.
Yeah. Well, the average, a recent study said the average time when primary care is 7.5 minutes. So, you know, which that is a problem.
Well, one tiny thing about Gary's diagnosis with onset Alzheimer's, and it says this actually on his paperwork from the doctor, from the neurologist. It says early onset Alzheimer's, but we're calling it Alzheimer's because we don't know what else to call it. We don't know the source of what this could be. So it may be more like the CTE from the sports injuries, CTE, I think.
CTE.
Yeah, and or you know, but that's so that he could get a Medicare code.
Yeah, that is unfortunately we have to, you know, do a lot of that for
I mean, it makes sense.
reimbursement. But one thing you might look into is and look into a cognitive therapist. Those are usually occupational therapists.
Okay.
They're often associated with hospitals. We refer to cognitive therapy where they give you brain exercises. I mean, just like we do physical and we throw in a few brain exercises, there are therapists that's all they do. And if they don't have someone in person, there are online options for cognitive therapists. So cognitive therapy is its own brain therapy, which I highly recommend.
Okay.
And it's covered. I mean, a lot of cognitive therapists are cash-based, but it is a covered service by Medicare.
Okay, thank you.
Mhm.
Anything else?
Good to talk to you again.
All right, you too, Gary. It's good to see y'all.
Yeah, it's with my eyes they've worked for a long time, and the doctor in what's his name?
Neurologist?
Yeah, well, he's not a neurologist. He's the only doctor west of the Pecos that does that.
Oh,
Yeah.
the one we're going to see in Lubbock?
Yeah, we're going to see him in Lubbock. He
Dr.
works
Friedman.
at Texas Tech.
Texas Tech Health Science.
Yeah, it is a limited. I know like Austin didn't have a neuro-ophthalmologist for years, almost more than 10 years. There was a pediatric neuro-ophthalmologist, and now we have someone, but you can imagine one person servicing a surrounding area of 4 million people. The average wait to a neurology is 5 months now.
Well, good.
And
I was
yeah.
about the same.
Yeah, so it's unfortunate, but
Right.
All right, does anyone else have any questions? We're gonna do this every month. I have to figure out for July because it's the first Thursday is July 4th. So I'll pick a new day, and today is D-Day, a day to remember of those who served and not to be forgotten. So for any of you who have loved ones or have served, thank you for your service. And it's it's a day to be humbled and grateful for all that the servicemen and women have done for us. All right. Does someone want to ask a question?
Is it possible to get the captioning for
Yes.
next meetings?
Yes, I promise.
I have
promise.
a captioning telephone, but it doesn't always write it exactly what is being said. And
I promise.
my balance issues, my dizziness,
Uh-huh.
was caused from a mistake made during my cochlear implant surgery. So I was either deaf totally when they were doing the surgery. It wasn't working right. So either they just closed it up and I would still be deaf, or they would finish the surgery a different way, knowing that I would lose my balance. And so that's what happened. So this is 7 years ago, 8 years ago.
And I don't know if you can hear me. I am sorry that you experienced that. It's not common, but it is a risk factor in a cochlear implant. And you have to think, we don't see everyone for dizziness or balance after a cochlear implant because they didn't have it. But we do see a fair amount after, and there are, with some of the new procedures, there is a risk for damaging the balance portion of the inner ear. And that's why we are advocates for balance testing before any ear surgery, middle ear, inner ear, to know what is the function of the ear prior to the surgery. Too often it doesn't happen. And then we see the onset of dizziness and balance after cochlear implant. So in the therapy world, we see those patients, but but we're seeing them because it happened. I have looked at the literature. There are some greater risk with certain types of cochlear implants, and some people would still choose it. But just knowing.
Many people have some balance issues and dizziness right after the surgery, but
Yes.
mine never went away, and I am a very rare case, and my doctor said that when they go to the convention, there's a convention once a year where all of the cochlear implant surgeons go to there, and I am the topic of what possibly could happen, but there's no one else at that yearly convention that has had a patient that had this as bad as I do.
Hmm. Well, again, I'm sorry that happened. I will promise to have captioning, and you can see Cynthia shared where her mother was denied a cochlear implant because of the risk. I think those are things we don't talk about enough. We see a lot of patients who have life-saving antibiotics to save their life, or cancer treating drugs to save their life, and maybe don't realize that completely damage both ears, can cause peripheral neuropathy at the same time. And it's not that they would have changed,
Yes,
it's
I
just
also
knowing. It's knowing that
I also have the problems with my feet.
yeah,
the
with peripheral neuropathy.
neuropathy.
And that does complicate. And
Yes,
if you think about vision loss,
your
so some
eyes,
people have,
your ears, your feet.
yeah, some people have vision loss, inner ear, and the feet, and all the sensory systems can be affected.
Yes.
Well, we'll do what we can to provide you resources. And I want to thank you all for
Okay,
joining, and I'd love for you to share your ideas of future topics. All right. Thank you all so much.
Thanks for taking the time to do this.
All right. Thank you, Cynthia. I appreciate
Thank
it.
you so much.
Bye-bye.
Hope to see you next week or
All
next
right. Next month.
next month.
Thank you.
Bye bye.